Good afternoon, everyone. Thanks for joining us. If you don't know me, my name is Rachel Schrader. I am VP of Clinical Care and Education at PPMD, and we're really happy to have you here today. We're joined by a couple of our colleagues from the team over at Roche to talk about a new clinical trial and program that they are currently running. And we're excited to hear a little bit more about that program, how it works, and make sure that you all are up to date with the latest and greatest. So we have two great folks here with us, and I'm going to have them introduce themselves. But before that, just a bit of housekeeping. Today's webinar is going to be recorded and available for playback after the conclusion of the meeting. So if you want to share this or go back and listen again, it will be available both on our website and on our YouTube channel. And we're also happy to take any questions that you have at the conclusion of the formal presentation. So as you listen today, if you think of any questions that you have, please feel free to drop those questions in the chat and we'll answer those all at the end. So with that, we'll go ahead and get started and we'll do some quick introductions and I'll hand things over to Sandra Bloom.
Hi, thank you so much, Rachel. And hello, everybody. I'm Sandra Bloom. I'm part of the Roche Patient Partnership team based in Switzerland, although I'm from the US originally. And we're a team that works together with patient organizations to try to ensure that Roche is really listening to the community and understanding the community needs and wants as we're thinking about the decisions that we have to make. And I'm really excited actually to be here today. I'm mostly going to be available for questions after the presentation, but super pleased to have Maitea, who's going to introduce herself next, presenting this clinical trial and also just the story of how we've gotten here. So Maitea, over to you.
Great. Thank you very much, Sandra. And hi, everyone. My name is Maitea Guridi. I'm a scientist by training, and I work as a development leader at Roche together with Sandra and our whole team. And I'm also very excited to be here today to share with all of you the work that we have been doing for the past year or so, where we have been trying to learn as much as possible about bone health in Duchenne to help us design our new clinical trial, which is called SHIELD DMD, which is testing or studying the potential of one of our molecules to target both bone health and muscle function in Duchenne. With this, I'll go straight into the presentation then. And a quick disclaimer in the beginning, as always, to explain that the content that I'm about to show you has no promotional purposes, and we're provided only for informational use. Our presentation, we thought we could divide it into three parts. First, we think it's going to be hopefully useful for the community to share with all of you the key learnings, our key learnings around how bone health develops and progresses in Duchenne. Then we want to introduce you, obviously, the details of our new clinical trial, which is called SHIELD DMD. And in the end, like Rachel explained, we will have hopefully a very nice, plenty of time for a nice interactive Q&A session where you can direct to us any remaining questions that you might have around bone health or trial, and we can try and answer as much as possible. So what exactly do we know about bone health in Duchenne? And actually, I'm going to be very transparent with you. Us at Roche, we have been working in developing medicines for different neuromuscular diseases, including Duchenne, for a long time now. But we were always focusing on the muscles, which makes sense. Duchenne, for example, is a muscular dystrophy. If we want to help people living with Duchenne, we should try and help the muscles. But we realized that, and this is all very well known as well, that Duchenne is one of those diseases that affects the whole body in the end. It has different implications around different systems and the whole body. And one of them is actually bone health. And it impacts the bones of people living with Duchenne. But we didn't know that much about bone health. So we've been working very hard for the past over a year. We teamed up with the actual experts who are neuromuscular experts, endocrinologists, even collaborated also with the community to try and build a common understanding of what exactly bone health means in Duchenne and what we could expect as the disease progresses, what we could expect around bones. And what we have learned is that one of the key facts is that there is a direct and very key communication between muscles and bones. And this is very important for everyone. So you can imagine different examples like, for example, a professional athlete. They tend to have very strong muscles, they will have very strong bones. On the other range of the spectrum, if you think of old people, like, for example, some of our grandparents, they might already be suffering from different fractures because with age, our muscles weaken, and this is in turn going to cause also weak bones. So what happens in Duchenne is because of the ongoing and progressive muscle weakness, this is also gonna in turn generate or cause the bones to weaken. And how this looks is often, we often talk about bone density. So this is how dense and how strong your bones are. In Duchenne, we know that the density is reduced, and this is also seen by pores in your bones. This is called osteoporosis, and this is gonna make the bones to be more fragile. And I think it's important to understand that one of the key signals for bone growth is actually called mechanical loading, which literally means weight bearing. So just by standing, by moving, by jumping, and all these activities, the bones are going to get that signal to continue growing and become stronger. In Duchenne, what happens is that this communication, this signal is lost because the muscles are slowly getting weaker, the activity levels are reducing, and we get weaker bones. In addition, so this would mean that there is a mechanical communication between muscles and bones, right? There's also what we call a systemic communication between muscles and bones. And this means that muscles, which is, by the way, I always say it's a fascinating tissue, but muscles are able to produce different proteins. You might have heard about myostatin, maybe TGF-beta. We are specifically interested in one of these proteins that the muscles produce, which is called IL-6 or interleukin-6. So muscles are able to produce all these different proteins that are going to go to different tissues, such as the bone, to communicate directly with them. And they can influence bone growth and bone fragility through these different proteins. Long story short, key message here is that healthy muscles mean healthy bones. And in Duchenne, what we know is that there is a discommunication between muscles and bones that are going to generate weaker bones. In addition, nothing new I'm going to tell you about, but it's also very well known that long-term corticosteroid use will have a significant negative impact on bone health. So corticosteroids are the approved standard of care to treat people with Duchenne because they're very well known to extend ambulation. They can delay loss of motor function and also even preserve cardiac function and respiratory function. Unfortunately, they also have quite a big list of unwanted effects. You may know some of these, which is growth delays, puberty delays, weight gain, and most significantly, where we're interested now and where we're focusing on is that corticosteroids are very well known to induce osteoporosis and cause bone fractures. So with all of this, what we've realized is that most of us, the companies, researchers, we have traditionally been focusing on finding new treatments to help restore the muscle function, which again makes sense. These are neuromuscular diseases. But we realize that there is a kind of a neglected aspect of the disease, which is this osteoporosis and bone health. And there are currently no approved treatments for bone health in DMD that could prevent all of these fractures from occurring. So we concluded there's a big unmet medical need to address bone health in Duchenne. Can we do anything about it? And one of the best examples of what bone health means to a person living with Duchenne is actually reflected in this one slide that I hope, with the permission of the PPMD team, we borrowed this one slide from one of their presentations. If you want to go deeper, dig deeper into the bone health aspects and endocrinology in Duchenne, there's a great video at the PPMD website by Dr. Leanne Ward and Adam sharing his journey with Duchenne and osteoporosis. And as you can see, in some of these, probably one of the most severe cases we might have encountered, but there's recurrent fractures happening in people living with Duchenne. Also severe complications of these fractures, which include fat embolism syndrome, several vertebral compression fractures. So this is a great example that there's really a big need for treatments to try and slow down, at least potentially, if we could even slow down the happening of osteoporosis, even prevent some of these fractures, we could really help improve the quality of life of people living with Duchenne. And this is something that we really wanted to try. And I guess one of the important things is that regarding bone health, there is a lot of information out there, but we had some difficulties also finding quite a consensus or a consistent story. And I guess it's relevant to explain that every individual is going to have a different experience, right? Not every person is the same. The disease is heterogeneous. We're going to have differences between different people. So we wanted to try and build kind of a disease model to help understand what a person living with Duchenne could expect regarding their bone health, what they could expect regarding bone fractures, and how their bones could deteriorate as the disease progresses. So we built this kind of story here based on, we went through all of the published literature, all the data out there from clinical trials, natural history studies, everybody who has been working with Duchenne. We collected all of that. We also corroborated this kind of understanding with the experts, and we came to this conclusion and consensus of how bone health could be expected to progress as the disease advances. And what we see here, I hope you can see my arrow. So we all know that at the peak of the motor function of the boys, we will likely start prescribing corticosteroid treatment around 5 to 8 years of age. The current DMD guidelines recently have started promoting and recommending the use of routine screening for vertebral fractures. This means that you should go, once you start with your steroid treatments, you should, or your doctor will recommend you to start having an X-ray of your back once a year so that we can start monitoring if the steroids are really damaging your vertebra, or if we can start seeing some of these vertebral fractures. However, the first fragility, what we call the fragility fractures that we expect to start occurring, it's around the age of 7 to 9 years old, and they tend to be first fragility fractures that are reported are of the long bones, so like your leg bones or your arms. And I guess before I continue, it's important to distinguish that we can all suffer from bone fractures, right? You fall on your bike, you get in an accident, unfortunately, you could break bones. But when we talk about fragility fractures, this means that from almost no trauma or very small impact, the bones, because they're fragile, they can break much easily. So what we're talking about here is these fragility fractures, because kids will, fall off the bike and they can break a bone. That happens everywhere. But with Duchenne, we know because of the fragility, it's easier to break these bones. And this will start, becoming more common around the age of 7 to 9. We also know that around 8 to 9 years, so approximately 1 to 2 years after having started regular steroid treatment, we can start detecting the first vertebral fractures. But there's also quite a phenomenon that we think we know that the vertebral fractures are often underdiagnosed because we don't necessarily follow this routine screening of having an X-ray every year. So we know some people might actually have some of these vertebral fractures. They might not be very painful, and until you make an X-ray, you have an X-ray, you're not able to diagnose it. So there could be some undetected vertebral fractures already happening by the age of 8 to 9. But if not, usually they're detected much later, around 10 to 12 years of age, once the patient becomes wheelchair bound and they start complaining about back pain. This is when we normally know people will report more and more vertebral fractures. At the same time, this is about the fractures, but we also know that the density of the bones, this bone strength, will progressively decline with age and as disease progresses. We know there's some kind of a milestone as well in traditional osteoporosis. We say that when bone mineral density scores go below -2, this is when the decline starts to be more significant. However, this is nowadays also know that even above these numbers, fractures can occur and complications will happen as well. So it's more of a threshold to say the decline will likely start to become more severe. And After losing ambulation, we know then that the rate actually accelerates because, as I explained before, because we're off our feet, the bones don't have that much of a stimuli and that much of a messaging from the muscles and the whole body. So the weakness sets really rapidly then, and the bone mineral density will decline much more after losing ambulation, and the risk of fractures also peaks at around 14 to 50 years of age. It's also important to understand that while we're talking about fractures and bone mineral density, they also have the risk of very severe complications, such as you saw in Adam's case. Fractures can lead to fat embolism syndrome and need for hospitalizations. A vertebral fracture is also known. There's a phenomenon that happens in Duchenne that is called the vertebral fracture cascade. So once the one vertebra breaks, we know this is gonna promote other vertebrae to break as well, because the spine will collapse in on itself. This is going to have an impact on spine deformities, the pulmonary function, because of the capacity of the chest. It's going to cause pain. And most significantly, also, we know now, based on the data, that over 1/3 of people living with Duchenne will actually lose prematurely, and permanently. Loss of ambulation will come early because of a long bone fracture. So this is obviously something that we could really work towards delaying this milestone. And lastly, another important thing to know, we know also that the fractures can occur at any time during the life of a person living with Duchenne, because they're at higher risk. But we also know that this risk changes with age. For example, when the kids are younger, by age 5, because they're still growing, the weakness has not peaked. So the risk for fractures is around 20% by age 5. This increases by age 10 to around 40%, because then the muscle weakness is set, the bones are also much weaker, we're losing bone mineral density, the risk for fracture is much higher, and it will peak at around age 15, where we would expect the risk for fractures to be as high as 80 to almost 100% of the people. And that was part of what we learned from the kind of looking into the natural history of the disease. But we also realized that we actually had some very valuable data in our hands from a previous clinical trial that Roche performed with Duchenne participants, which is called SPITFIRE. This was a clinical trial to assess the safety and efficacy of our previous anti-myostatin molecule. And we enrolled and recruited boys with Duchenne that were aged 6 to 11. We treated them with this anti-myostatin for almost a year. Unfortunately, the study was terminated early because of lack of efficacy of the anti-myostatin molecule. But I cannot repeat this enough. We want to make sure that the community understands that even if a trial is terminated and the molecule doesn't work, the trial was very successful in helping us collect very valuable data. And this is one of the best examples where we can show you how we can use the data, we can use the samples to figure out new things about the disease and try and come up with new solutions. So we dig deeper into the data we had in our hands from SPITFIRE, where we actually did a DEXA scan. So this is, I forgot to mention that, but this is how you measure the density of the bones, is through a DEXA scan. Some of you might be familiar with this already. And we did a DEXA scan every 6 months and within this year. And as you can see in the graph here below, it was a very interesting observation to see and to kind of confirm and corroborate what we also knew, but it was never really set in our understanding, which is the younger the participant, so around 6 years of age, the bone mineral density score, this is the total body less head bone mineral density scores, they were higher compared to the participants that were approximately 11 to 12 years of age. So already we can see this impact of age, the impact the age will have in this decline in the bone mineral density values. And what we also saw is that almost invariably, every participant would continue showing losses in their bone mineral density by 6 months and a year, right? You can see all of these 3 dots going always towards a downward. And another very interesting thing we learned, because usually when we talk about data and science, we look at a group of participants and we talk about means and averages. But sometimes these means might not be the best, most representative of one to specific individuals. We have a lot of variability. Every individual will have a different experience. What we saw in SPITFIRE when we looked into every individual participant data is that almost 80% of the participants were actually showing a loss of bone mineral density within this 1 year time period. And this will also continue to decrease with time. So for us, it was a very eye-opening thing to see that it's a very kind of predictable and expected progression that bone mineral density will continue to decline with age. And what this translates into is that because of our bones become less dense, they become more fragile, this also increases our risk for fractures. We saw that. And from all this published data, we collected, I think it's data from almost 2,000 people. So people living with Duchenne, we collected the data from the literature, and we created these graphs where we can see how age has also a significant impact on the proportion of participants or people that will show fractures. So the older the age, the higher the proportion of people showing fractures, bone fragility. In addition, I explained in the beginning that we know corticosteroids will have a severe impact and cause osteoporosis. And we also see this with all of these 2,000 people data, where the longer the duration of corticosteroids, the higher the amount of people showing fractures. And what we thought is also quite interesting to know and learn is which are the most commonly reported fractures in people living with Duchenne. So we saw from this analysis and this data that the femur is actually the bone that is most frequently broken in boys with Duchenne. And at the same time, we now know better about vertebral fractures. It's not reported here, but because of this lack of systematic monitoring of the spine and detecting vertebral fractures more systematically, there's not as much data, but we know that vertebral fractures also usually account for approximately 50% of the reported fractures in boys living with Duchenne. So this is a very, I guess, impactful view of describing what bone health means in Duchenne. And what I've shown you until now, these are facts. We were not making anything of this up. We just collected all of this data available, talked to investigators, and we are now able to understand that, as I explained, because of the muscle weakness, this will lead to osteoporosis and cause this recurrent or increased risk for all of these fractures to occur as the disease progresses. And this is also worsened by the long-term corticosteroid use. Now, what I'm going to show you next in this slide is how we would want to try and fix this or try and help mitigate some of these problems by focusing on one of these dysregulated proteins that the muscles produce, which is called this interleukin-6 and IL-6. And why are we specifically focusing on IL-6? I guess that's a good question to answer. So we know that IL-6 is a protein that promotes inflammation. We believe that in Duchenne, so this is more of our theory, where we think that in Duchenne, because of the ongoing muscle damage, the muscle is going to produce these dysregulated IL-6 levels. We also know that the IL-6 pathway is altered in Duchenne muscles. So this overproduced IL-6 can in turn continue damaging the muscles on its own already, so continue to promote all this inflammation and damage. But IL-6 can also go to other tissues, such as the bones. And we know that in the bones, IL-6, we took this example from other diseases where we know that IL-6 can induce different cells to basically eat at the bones. This is called bone resorption. So there's IL-6 can activate different cells, as you can see in this cartoon, to promote bone resorption, to eat at the bones and cause this osteoporosis. So what we think is that in Duchenne, IL-6 might actually be one of the key, might have a key role in bone loss in Duchenne and be causing or be contributing to these ongoing fragility fractures. And this is our hypothesis now, and this is our theory, where we wanted to test whether blocking the IL-6 protein could in turn reduce the damage to the muscles and reduce the damage to the bones that we observe in people living with Duchenne. And this is where we came up with our new clinical trial, which is called SHIELD DMD, where we want to test the potential, the safety and efficacy of satralizumab. This is our new molecule, which is it's a molecule that we block the IL-6 receptor or the IL-6 signaling pathway. And we want to test whether it's efficacious in targeting both bone health and muscle function in people living with Duchenne. It's a global study, and we plan to recruit boys aged 8 to 15 years old. We are currently opening clinical trial sites in Italy, Poland, and Spain, and of course in the US. I can give you, luckily, a bit more details than what we showed. We already presented some of these details in June at the PPMD conference, and I'm happy to share with you now that we already have two hospitals, two sites that are open and already screening for participants. So one of them is in Virginia. You might be familiar with Dr. Crystal Proud from the Children's Hospital of the King's Daughters. They're now screening for participants. And another site that we have opened recently also is in Michigan with Dr. Yena Kruger, who is at the Corewell Health Hospital in Grand Rapids. Also, they're currently screening for participants. And we'll be soon opening sites as well in Texas and New York, hopefully by the end of October, and new sites also in Ohio by November and Georgia by December. So if you wanna, if you're curious about the details, if you wanna get in touch with any of these sites, you should check clinicaltrial.gov for updates on how we, currently are in opening sites and who you could contact to ask more about the study. I can tell you a little bit more about the study. And in case you were wondering why we propose satralizumab as a molecule who potentially could target muscles and bones in DMD. This is because satralizumab can block IL-6 signaling. Satralizumab is what we call is an antibody. So it's a protein, it's a molecule designed from human proteins. It's called a monoclonal antibody, and it's able to bind to the IL-6 receptor and block the signaling or the acting of the IL-6 protein. It's injected subcutaneously, which means under the skin, every 4 weeks. And what we want to achieve is blocking this IL-6 receptor. We could reduce the inflammatory action of this IL-6 protein. And what was interesting, we also, from the SPITFIRE trial, we also used some of the blood samples that were donated by the participants. And we did an analysis, internal analysis, where we checked different levels of different proteins in this blood. And what we saw is that IL-6 receptor levels were actually increased in the blood of the participants with Duchenne compared to healthy age-matched kids. And they also, what we saw was very interesting, is that the IL-6 receptor levels correspond to bone mineral density in these participants. So we saw that the higher the IL-6 receptor levels, the lower the bone mineral density of the participants. And we're hoping that by targeting the IL-6 receptor, maybe we might be able to balance again towards a better bone mineral density. So this is why we're testing the potential of satralizumab in the SHIELD DMD study. And I guess one of the advantages of using satralizumab, so one key thing is satralizumab is approved already, so it's been used commercially to treat another disease, which is called NMOSD. And I would say you don't need to know anything about NMOSD, but luckily we do know a lot about NMOSD. Satralizumab has been used to treat many, many patients with NMOSD. It's approved in different countries. And we're also, at Roche, we're also trying to figure out the potential of satralizumab to treat other neurological and eye diseases. And at the same time, we realize the potential of satralizumab to bring benefit to people living with Duchenne. So this is now part of our plans to develop satralizumab further. And what we know is that for now, with all of this experience that we have, over 9 years of data collected from satralizumab, the safety profile, it's what we know is that it's a well-tolerated molecule. The most common adverse reactions that we see to this treatment, you can see them here on the left. It's which usually happens in more than 10% of patients, for example. they would report decreases in white blood cells, headaches, joint pain, and quite common with this type of molecules are injection site reactions, right? We are injecting this drug through the skin, so we know this can generate some both local and systemic reactions, such as, on the skin, you might see some swelling, rash, itching, and also you could get some diarrhea or headache as a consequence of receiving satralizumab. Also important to know, obviously there's some contraindications that we have learned from the experience of treating different people with satralizumab, is that obviously you should not take satralizumab if you have any if you're allergic to any of its ingredients, and especially if you have active hepatitis B infections and also tuberculosis. So the good news for us is we're learning a lot about satralizumab. Keep in mind that even though it is approved for an MOSD, it is still an investigational drug for Duchenne, right? We've never treated people with Duchenne with satralizumab. So this is going to be the first time that we test it in Duchenne. And we're going to do this through a 2-year clinical trial. So Shield DMD is going to be 2 years in total. We're going to have a approximately 3 months screening period where we will screen participants to figure out if they qualify for this study. I will tell you a little bit about the inclusion-exclusion criteria later on. And in this study, it's called an open label study. So every participant will get satralizumab. So at the baseline, once it's confirmed that you could be eligible to participate, you will get as an injection with satralizumab every 2 weeks. In the beginning, there's called 3 loading doses. So you get 3 injections within 1 month, and afterwards, the participants will get satralizumab every 4 weeks. We're going to be looking to different endpoints and different tests that we're going to be measuring. So we definitely want to look into biomarkers or proteins that are involved in bone metabolism to see if satralizumab can influence bone metabolism at all. We're also going to be doing a DEXA scan, obviously, every 6 months to measure the density, if the density of the bones changes, and also an X-ray every year to continue measuring. The fractures, we're going to be checking into fractures. The long bone fractures are quite easy to report, right? They're very visible, but we're also going to be doing a yearly X-ray to assess if it has any impact on vertebral fractures, and if we're able to prevent also both long fractures and vertebral fractures. And after the last dose of satralizumab, or if the participant wants to leave the study early, we will do also a 3 months safety follow-up, just to make sure that there's no ongoing consequences from the treatment. So our key objective with Shield DMD is first looking into whether satralizumab can target bone in Duchenne. So we're going to be looking into changes in the bone mineral density from baseline to 1 year. Additionally, as key secondary objectives, obviously we want to make sure that the drug is safe to be used in Duchenne. Also additional changes in other bone mineral density of different bones of the body. And regarding muscle function, we still want to assess whether satralizumab can reduce muscle inflammation, can prevent loss of muscle function. And this is why one of our key secondary objectives is going to be time to rise from the floor, a very commonly used motor function test in neuromuscular diseases and in the clinic. So we're going to be looking into changes from time to rise from the floor from baseline to a year in those participants who are actually still ambulatory and can walk. And obviously, as I said, we're going to be counting and measuring the number of fractures, both long bone and vertebral fractures. So this is going to be my last slide, actually. This is to give you a high level. There's going to be additional inclusion-exclusion criteria, but I think the most important ones are reflected here, which is we're going to be recruiting male boys with DMD who are between 8 and 15 years of age, with a confirmed genetic test for Duchenne. We're going to be recruiting both ambulatory and non-ambulatory participants, but all of them have to be taking daily oral corticosteroids for at least 12 months. And I think this might sound a little paradoxical because we just said how bad corticosteroids are for your bones, but there's a key reason why we require in all of the studies recruiting people with Duchenne. We know it's a standard of care. We know it can have an impact on your muscle function and also on your bone bone metabolism. So we need to somehow homogenize and stabilize the impact of steroids. By requiring everybody to be on steroids from the beginning, we are reducing that potential variability into the muscle function and into the bone metabolism, so that we can then detect the treatment of satralizumab hopefully better in the results. So we're going to be recruiting 2 groups of participants. The group 1 are going to be those who have already broken a bone before, so they're already showing manifestations of their bone fragility, and these are going to be ambulatory participants aged 8 to 11 with a broken bone before. This can be any time during your previous years, and also non-ambulatory participants aged 12 to 15 who have shown a broken bone before as well. Long bone, vertebral fracture, everything will be eligible. And then in group 2, which is going to be a bigger number of participants, we're going to be recruiting 8 to 11-year-old ambulatory participants who are able to stand from the floor, also rise from the floor below 10 seconds, and have not yet broken a bone before. So what we want to do with these 2 groups is study whether satralizumab can prevent or slow down or delay. We have to see, right, with the data, whether the occurrence of the first fracture, this will be for group 2, or in group 1, if we can prevent additional fractures from occurring. And the last important key thing to keep in mind, I think we're always interested in knowing what other therapies might be allowed to participate in this trial. So currently, we are prohibiting some of the medications, such as gene therapy, exon skippers, givinostat. These are prohibited medications at baseline and during the first year of our study, because we need to have, let's call it like, we need to look at the data in a clean way. If we have all of these different therapies, this is gonna, we know they have an impact on the muscle function. This is gonna generate some variability that we need to avoid. So during the first year, these medications are prohibited, but the study is 2 years long, and we do want to generate during the second year data on potential combination of these different therapies. So within the second year in Shield DMD, participants will be allowed to go into gene therapy, exon skippers, whatever they're eligible for, and givinostat as well, so that we can also start generating that very valuable data of how the combination of different therapies could contribute to improve the quality of life of the different participants. And this was the last detail of our studies. With this, I would really want to take a minute to thank everyone, the families, the people living with Duchenne who take part not just in our clinical trials, but in any research. As you can see, this helps everyone understand the disease much better. We can progress the science, and we can come up with new potential solutions and treatment possibilities. And also a big thanks to patient advocacy groups, and the caregivers also, to actually help us design these trials, because we have had some very great interactions with the patient community to understand how to optimize the design of our clinical trial. And before I forget, a huge thanks to PPMD, by the way, for giving us the opportunity for the second time to share our story with the Duchenne community. Thank you so much for your great collaboration, and a big shout out to the team at Roche behind this whole project, and Sandra as well, who's here, for working so hard to helping us, make this a reality and get us to where we are today. And thank you everybody for your attention. We'll be happy to take any questions you might have.
Wonderful. Maitea, thank you so much. I learned so much from that presentation, both the basic science of what you learned in SPITFIRE and what you learned using some of those DEXA reports, as well as some of the blood studies, as well as the structure of this new clinical trial. We have lots of questions. So I think what we'll do is start with the questions in the chat, then we'll go to the ones that were submitted in advance. And then if we have time, I have a whole long list. But we can start with some of these questions here in the chat. And this first one is a great question about those individuals who participated in that initial SPITFIRE study. Do you know if any of those individuals were on bisphosphonates at baseline, and if that had any sort of impact on the data that you were able to elicit?
Very good question. We actually were curious about that, and we looked, and we do know some of them were receiving bisphosphonates, but the numbers were quite small, and we did do a different, analysis of the data, but we didn't see any significant impact, to be honest with you. But because, the numbers are very small, the value was high, so we did look into the data, separating, bisphosphonate use or not, but we didn't reach to any very good conclusions, to be honest.
Okay, and
Too
then this
little
next
data, I think,
question.
unfortunately.
No, I think that makes sense. That's really helpful. And this next question is related. And will participants in this clinical trial also be permitted to be on bisphosphonates at baseline? Because those are folks who have potentially had a fracture before, and they're different drug classes as far as I can tell. Can you speak to that at
Yes.
all?
So this is a very complicated issue. We realize that if we want to recruit participants who have had a broken bone before, they will likely have received bisphosphonates, or they could be in ongoing bisphosphonate treatment. But we know that bisphosphonates can have a significant impact on the bone density, right? They are anti-resorptive therapy. They have been shown to improve bone mineral density. So unfortunately for our trial, we're actually requiring a washout period of bisphosphonates. And this is something we very extensively discussed with the advisors, because we can't, you can't ethically require somebody who has had a fracture not to take bisphosphonates. So what we are trying to find is those participants who are about to receive their next dose of bisphosphonates. Usually IV bisphosphonates are given every 6 months. This is the, I think, most frequent treatment with bisphosphonates. So what we're saying is that before you take your next bisphosphonate dose, you can enroll into Shield DMD and receive satralizumab instead, which should have, based on our theory, a similar effect, hopefully even better, a better safety profile as well. So we don't want to prevent people from taking bisphosphonates, but because we need to avoid that variability in our data and reduce the noise that bisphosphonates could create regarding bone mineral density, we require a 6-month washout of bisphosphonates prior to baseline.
Okay, you just answered my next question. I was going to ask how long that washout is. So you could feasibly take your, pamidronate or your zolendronate, and then 6 months later, you could start satralizumab and then do that 2-year period. Okay, I think that is really helpful.
Yeah, and in case some people are curious about that, so we are just starting screening now, and we plan to first recruit the non-ambulatory participants before the end of the year. And then additionally, we'll continue recruitment of participants early next year. So there's still also time to figure out if you could qualify based on your previous different treatments.
Okay, that's great. The next set of questions are related to use of approved therapies. And I know, Maitea, you had a really nice slide that covered all of the approved therapies. So gene therapy, exon skippers, juvenistat. And so I want to just reinforce. So you said the first year you would not be able to be on those drugs, but then during the second year, you could start those drugs with a goal of understanding the effect of combination therapies. Is that right?
Right. Yeah. So at baseline, people who have previously received this therapy, so gene therapy, for example, is exclusionary. Exon skippers and juvenistat, you have a washout period of 3 months.
3 months.
All of these at baseline, they're exclusionary. They're prohibited also within the first year. Then if you qualify and you want to try and you're prescribed, you are allowed to take additional approved therapies during the second year of the study.
What?
And maybe
go ahead.
I was going to say vamorolone is not mentioned here, but it was also recently approved. So vamorolone is the same. It's excluded at baseline, prohibited in the first year, but then allowed during the second year.
Okay, so I think there's 2 things there. So with the daily steroids, I'm then taking from that the participant would have to either be on daily prednisone or daily deflazacort, but daily vamorolone would not be able to participate. Is that correct?
Yeah.
Okay,
and
perfect.
I can explain quickly why, because we know with the data that we have seen in the trials from vamorolone, they see that vamorolone might be less harmful than traditional steroids on their bone metabolism. So if we allow participants that are taking vamorolone and mix them with participants that are taking deflazacort and prednisone, this is going to change. This is going to show differences in bone metabolism that we want to avoid, obviously, to try and detect changes in metabolism that are due to our treatment and not any other differences in steroid treatments.
Okay, that makes perfect sense. Now, how does this concept of delayed access to approved therapies relate to the use of Adalurin or Translarna? So that's not currently approved here in the US. I know lots of folks are on it through, open label extensions, but it's been accessible in Europe. So what about those European sites? Can those kiddos be on drug, or is that a washout second year situation?
Also a washout. So we consider Adalurin and Translarna to be also similar to exon skippers because they can modify dystrophin expression. So it's also included in the prohibited medications at baseline, requiring a 3 months washout. So any treatment targeting dystrophin expression would be excluded at baseline.
Okay, so I'm going to summarize to make sure that I have it right, and I'm pretty sure that I do. So absolute contraindication or absolute exclusion, rather, if someone has received gene therapy, a 6-month washout from any other bisphosphonate, whether oral or IV, but 6-month washout for other bone-sparing medications, and then a 3-month washout for other approved therapies like exon skipping medications, Juvenistat, Adalurin, etc. Is that right?
Summary.
Perfect. Okay, cool. I anticipated there would be a lot of questions around this. It's becoming an increasingly complex landscape, which is both a good thing and a complex thing, right?
I know it's a great thing for the community, and we're super happy about this. Like, the more treatments, the more options we get, the better. But for us, developers and scientists, it makes our life very complicated. So we're trying to find the middle best compromise where we obviously don't want people, prevent people from taking treatments that could help them. But in order for us to understand whether there's a possibility for additional treatments to still bring additional benefit, we need to have a scientific, clean experiment. And it's very complicated with all of these different treatments.
It is, but I do want to commend you all over there for being mindful of the other approved therapies and allowing folks to start those approved therapies in that second year. I think that's one of the biggest questions that we ourselves on the advocacy side are asking and hearing from the community. How do these drugs work together? Can they work together? Can they be safe? Is there benefit to having multiple drugs on at the same time? So I think that there's a ton to be learned from that. So we are very, very grateful for that. Okay, I think we have covered the majority of the questions in the chat. Ooh, here's a good one. I actually had this question written myself. So since it's technically approved, could it be prescribed off-label?
I don't think I'm at liberty even to answer to that question.
I couldn't help myself.
I know. Honestly, we shouldn't. Right? Technically, I guess it could, but we shouldn't. We don't really know how this works in Duchenne. We really need to do the trial, get the data, and understand if it can really benefit people living with Duchenne. We shouldn't.
That's a completely fair response. So I appreciate your candid comments on that. I know it's a tricky one to navigate. Okay, I am going to go over and look at the list of questions that we received in advance of today's webinar. Thoughts on inclusion of adults with Duchenne for this clinical trial? They're not really included in the current trial design, but this is definitely a population where we see some pretty significant bone density issues. Any future plans or comments about adult inclusion?
Yeah, no, definitely. I mean, we are continuously trying to increase the reach for the treatment. We know that one of the biggest unmet medical need is, as you saw, the older the people living with Duchenne, the more severe the complications get. But we also, for this trial specifically, this is the first time that we're testing the drug. And we try to narrow down the variability in the population. So this is why we went with 8 to 15, where we there's more data out there. So from all the research we've done, all the literature we've checked and the data, it's mostly focusing on 8 to 15. So we kind of understand better how the disease progresses from 8 to 15. And this is the population that we have selected for this phase 2 study, first time that we're testing. But definitely, if we do see a positive signal here, we will continue developing the drug, and we will include, we will include adult participants as well to expand that understanding of how the drug could bring benefit to all different ages.
Excellent. And Sandra, I'm going to throw you a little bit of a softball here. How can patients and families get in touch with the team at Roche if they have questions? Who should they reach out to? Should they reach out to Roche? Should they reach out to clinical sites? What does that communication look like?
Yeah, thank you. Generally speaking, the best path to go down is to reach out to the clinical sites. But we do have some information available. We actually have a website called For Patients. So if you search For Patients at Roche and plug in Shield, you'll find some information on there about the trial. We also always recommend going to clinicaltrials.gov.
Excellent. Thank you so much. All right, this next one, I think I'm actually going to field myself, but I'll read it aloud. And the question reads, would you recommend any vitamins or supplements that might help our boys decrease the demineralization that occurs more often in them? So I'll just remind everybody, Maitea is a PhD scientist. She's not a physician. And so that's a little bit of a tricky thing that we have to balance together when we think about science versus clinical questions. This is an awesome question. So I can share that we typically are going to recommend things like vitamin D and calcium to help optimize bone health, but really we want to direct a lot of these types of questions back to your neuromuscular team and your endocrinologist. If you don't already have one, please reach out to us. Let us know. We can help get you connected to an endocrinologist in your area, most likely in connection with a certified Duchenne care center. We're also really grateful for the work that Dr. Leanne Ward out of Children's Hospital of Eastern Ontario in Ottawa, Canada is doing with her Optimized DMD Consortium. And this is a consortium of endocrinologists from across the world, really, as well as some other clinical experts in other areas like cardiologists, neuromuscular experts. And they're working really, really intensely on updating the standards of care for endocrinology-related Duchenne care. So things like bone health, things like puberty, things like adrenal suppression and the use of steroids. And so that's something that we are really grateful to Dr. Ward and her team for, and we look forward to sharing in much more depth in the coming months as we're able to, which is really exciting. I did want to, oh, sorry, go ahead, Maitea.
Thank you for answering to that question. Obviously, I'm not a physician and I cannot do any medical recommendations. From a scientific perspective, I can share with you what the data says, and what we know is that there is often vitamin D sufficiency in people with Duchenne, and the care guidelines do recommend, supplementing this with vitamin D and calcium intake. But obviously, ask your doctors and physicians whether this is the right treatment for you.
Absolutely. And if you aren't sure who to go to, you can always flag it for the team at PPMD and we can help point you in the right direction. You can shoot me an email at careteam@parentprojectmd.org. Maitea, I really like this question here about demineralization of long bones and fracture rates versus compression fracture within the vertebra. Will satralizumab be effective in both, or kind of where are you focusing your attention in this study?
Very good question. At this stage, on both. We don't really know. So because we're focusing more on the IL-6 pathway and not necessarily steroid-induced fragility fracture. So we know that corticosteroids, for example, do tend to attack more of what is called the trabecular bone. And this is the bones on your vertebra. So we know that because of glucocorticoid treatment, there's a much higher incidence on vertebral fractures. But satralizumab is going to be targeting this IL-6 pathway, which is more the inflammatory mechanism. We know inflammation can damage bones, can damage muscles, but inflammation can also damage bones. And we don't yet really know if this is going to have a different impact on your vertebral bones compared to the long bone. So at the moment, we're going to be the hypothesis and the potential is for both. And we're going to be measuring the mineral density of the lumbar spine and also of the long bones to see if there's any potentially different mechanism of action for the fractures in these different bones. But at this stage, we hypothesize we can target both. We will see with the phase 2 data if we can prevent demineralization of both types of bones.
Excellent, excellent. Okay, cool. And then I have a few of my own questions, if that's all right. I know that we only have about 5 minutes left. Since this is already approved in another disease space, will there be any dose finding within this study, or is this just a predetermined single dose?
Very good question, actually. So because it is approved for another disease and we're also developing, we have quite a lot of data about the dose. We're currently proposing the same dose regimen that is used for the other diseases. However, because again, this is the first time we're going to be testing this in Duchenne, what we want to do with the first 8 participants, 8 to 10 participants, actually, we're going to do what is called the PK analysis, where we want to first confirm that the dose is actually correct for people living with Duchenne. So we will collect data from these first 8 participants to confirm that the dose we have selected is also appropriate for Duchenne.
Excellent. Okay, that makes great sense. And then you mentioned this is a subcutaneous injection given every 4 weeks. How does that translate to drug administration, whether it be at home or in the clinic? Is this something that families can administer at home, or are they going to have to come into the clinic for every injection?
No. Yeah, that's a very important. So we were trying to design the trial to minimize participant burden, and we know coming to the clinic, it's often very complicated. So we do require the first 5 injections to be done at the clinic, so that we can monitor any potential allergic reactions to the drug, or any swelling of the injection site. So the participants are going to receive the first 5 doses with the study team. And during those 5 first doses, also, they're going to be learning how to self-administer, or how to, for the caregiver to do the injections at home. So after the 5th injection, then they're going to be given satralizumab, and they can administer every 4 weeks at home themselves.
That's wonderful news. That's really great, and gives us a nice opportunity to minimize those trips to clinic, especially for folks who are traveling a distance. That's great. And then, okay, any thoughts on potential open label extension study after that 2-year period? Will drug continue to be available?
So we do have a very kind of strict policy at Roche that whenever the participants that have collaborated with us for a clinical trial, if they want to, as long as our drug development has not stopped, as long as we haven't shown that the drug is not safe, or we have stopped developing satralizumab in DMD because either it's not safe or it's not efficacious, we do commit to continue providing the drug and satralizumab to those who participated in our clinical trials, until at least it becomes available on their, the country. Once the drug is approved, then they can receive it, through commercially. But until then, we do commit that those who participate in our clinical trials, as long as the drug is still safe and we're not stopping development because it doesn't work, they will continue receiving satralizumab until it becomes approved.
Okay, great. Cool. All right. I don't think
Anything that we can do, right?
It's a tough question for a lot of companies, and so we're really grateful for that commitment to the community. I think that this is just a really beautiful story when we think about all of the participants in SPITFIRE, and I know that we were devastated when that didn't come to fruition, but to see that data being utilized in the way that it was to really tee up the SHIELD DMD study is really exciting, and we're really grateful to have Roche back in the space. And yeah, I think, we're really excited to see what comes of this. So we are at 1 minute left in the hour. Maitea, is there anything else that you want to leave us with today before we conclude?
No, I would just say, there we go. Thank you so much for joining us. Thank you for listening to us. We're super excited, as Rachel said, to continue the collaboration with the community. We've been invested in this for a long, long time, and we're really excited to start seeing some data, results, and whether this can really help, and we can continue, bringing benefit to the people living with Duchenne. And thanks everyone for the wonderful collaboration so far.
Awesome. Well, thank you so much, Maitea and Sandra, for joining us. Thank you, everybody who called in and listened. We're really grateful to have had you here. The recording should be available for playback here in the next few days. And if you have any questions in the meantime, whether for the Roche team, for PPMD, feel free to reach out to us and we'll point you in the right direction. I mentioned my email address, rachel@parentprojectmd.org, or you can email the care team @parentprojectmd.org. And that will go ahead and conclude today's webinar. Thanks, everyone.
So much.